Driving pressures in lung protective mechanical ventilation, a detailed overview. Hello, welcome to Medical Specialists Associates Educational Series on Critical Care Topics. I am your presenter, Christopher Voss, MD, board certified in critical care and neurocritical care medicine. Today, we'll delve into the critical concept of driving pressures in mechanical ventilation and how it ensures lung protective strategies in the care of critically ill patients. Understanding driving pressure. Driving pressure is defined as the difference between the plateau pressure, P-plat, and the positive end expiratory pressure, PEEP. It represents the pressure required to inflate the lungs and is calculated using the formula driving pressure equals P-plat, PEEP. Significance of driving pressure. Driving pressure is a crucial parameter because it reflects the stress and strain applied to the lungs during mechanical ventilation. High driving pressures are associated with an increased risk of ventilator-induced lung injury, VILI, and poor patient outcomes. Lung protective strategies. Lung protective strategies in mechanical ventilation aim to minimize VILI by using lower tidal volumes, optimal PEEP, and careful monitoring of driving pressures. The goal is to keep driving pressures below 15 cm H2O to reduce the risk of lung injury. Supporting driving pressure. A landmark study by Amato et al. Demonstrated that driving pressure is a better predictor of mortality in ARDS patients compared to tidal volume or PEEP alone. 1. This study emphasized the importance of minimizing driving pressure to improve patient outcomes. Application in clinical practice. In clinical practice, it's essential to regularly measure and adjust driving pressures. Strategies include optimal PEEP titration, adjusting PEEP to balance oxygenation and minimize overdistension. Low tidal volume ventilation, using tidal volumes of 4-6 ml/kg of predicted body weight to reduce alveolar stress. Regular monitoring, continuous assessment of plateau pressures and driving pressures to ensure they remain within safe limits. Practical considerations. When managing a mechanically ventilated patient, consider the following. Assess lung mechanics. Regularly measure plateau pressures and PEEP. Adjust ventilator settings. Based on driving pressure measurements, adjust tidal volume and PEEP accordingly. Individualized approach. Tailor the ventilation strategy to the patient's lung mechanics and disease state. Beneficial clinical outcomes. Adhering to driving pressure guidelines can lead to several beneficial clinical outcomes. Reduced mortality. Lower driving pressures are associated with decreased mortality rates in RDS patients. Improved oxygenation. Optimizing PEEP and reducing tidal volumes can enhance oxygenation without causing additional lung injury. Decreased incidence of barotrauma. By minimizing overdistension, the risk of barotrauma and volutrauma is reduced. Shorter duration of mechanical ventilation. Patients managed with lung protective strategies often experience shorter durations of mechanical ventilation and ICU stays. Better long-term outcomes. Reducing VILI can lead to better long-term pulmonary function and quality of life for survivors of critical illness. Recent advances in research. Recent studies continue to explore optimal methods for managing driving pressures. Research is focusing on individualized PEEP titration strategies and the role of advanced monitoring technologies to better assess lung mechanics in real time. 3. Case study example. Let's consider a case study of a 65-year-old male with RDs. Initial ventilator settings included a tidal volume of 8 ml/kg and PEEP of 5 cm H2O, resulting in a plateau pressure of 30 cm H2O. The driving pressure was 25 cm H2O, indicating a high risk of VILI. Adjustments were made to lower the tidal volume to 6 ml/kg and increase PEEP to 10 cm H2O. The plateau pressure decreased to 25 cm H2O, and the driving pressure reduced to 15 cm H2O, aligning with lung protective strategies. Conclusion. In conclusion, driving pressures are a vital component of lung protective mechanical ventilation strategies. By minimizing driving pressures, we can reduce the risk of ventilator-induced lung injury and improve patient outcomes. It is essential to incorporate regular monitoring and individualized adjustments in clinical practice.